I'm Poppy. So it says right there, I'm a community nurse. So I'm a trained RMN, but I work as a learning disability nurse. And that's one of the great things about nursing. You can kind of swap about and change routes, which is what I did. And yeah, I work in a community learning disability and autism team in Suffolk. So I thought I'd sort of pick your brains a bit. So this is someone who I work with, obviously changed their name. So they're 36. They've got a moderate learning disability, ASD, which stands for autism spectrum disorder, traits of EUPD, which is emotionally unstable personality disorder, an underactive thyroid, hemiplegia cerebral palsy, so it affects 2 limbs, a history of psychotic depression, 2 past admissions, and there's history of trauma and childhood sexual abuse resulting to her being a looked after child. So the situation is Jane is currently presenting with behaviours that challenge, which include shouting, screaming, extreme fluctuation emotions, with a liability and volatile nature to her mood and presentation. She's had an increase in urinary incontinence, and fecal smearing is currently within her presentation as well. Jane lives within a shared group home where she's putting other vulnerable adults at risk with her presentation and is limiting what activities is happening. So social work is aware and is currently trying to go to panel to get more one-to-one hours for Jane. Her medication's there, so levothyroxine is for her thyroid, risperidone is an antipsychotic, but in small doses it can also be used to help with the management of those challenging behaviours. Sertraline is an SSRI and an antidepressant. Aripiprazole is an antipsychotic, PRN promethazine, and PRN lorazepam. So promethazine is it's a PRN. It's like a sedative nature, but it's mainly made up from antihistamines. And PRN lorazepam is a benzo, and obviously PRN diazepam as well. So it's the next day. And someone rings up our duty line and they say Jane's behaviour has increased and she is now hitting other residents and smearing in the bathroom, which is now affecting other residents using the bathroom. She's becoming more and more confused, and the care team are now making decisions to keep her at home as they have too much anxiety to take her out with fear of these incidents and her recent increase in sexually disinhibited behaviours. They want to reduce these incidents. They want to reduce these behaviours, and know she was on PRN diazepam in the past, so we're looking to have an urgent medication review for this to be prescribed. They can't cope even with the additional one-to-one in place at the moment, and fears run high that this is leading to a placement breakdown and or a route to admission. So if someone rings up, have you got any ideas sort of what your actions would be at all with lovely Jane Doe? So this is what one runs through all of my mind. So we'd look at doing physical health checks. When was the last annual health check? Yeah, I'll check for a urine infection. Yeah, definitely, 110%. I'd check when their last dentist appointment was. I'm sure we all know the pain of toothache, and it is hideous. Are they in pain anywhere? Is there any side effects to any medications? Some medication side effects can lead to your tonsil, lead to you having tonsil stones, and like your salivary glands can become like infected and they can be extremely painful. If we're doing blood tests, do we need to do gradual exposure to blood tests, which is that desensitization work? Harmful working cultures, poor management and leadership cultures impacting on patient care, which links to that they straight away wanted to have more PRN instead of looking at was there anything going on in the environment around them. We need to look at least restrictive practice, and actually are they putting restrictive practice in place? Have they got a DOLS in place? Because if she hasn't got a DOLS in place, they can't really legally stop her going out. A mental capacity assessment, looking at best interest decisions, UTI effects, and constipation. Sometimes when people have constipation, they do a lot of smearing behaviours. And we know constipation is a huge cause of concern from our leader reports, which explores the learning from the deaths of people with learning disabilities, because someone with a learning disability, only 1 in 4 people with a learning disability will live over the age of 64. The other people will sadly pass away. We need to think of person-centered planning. Is an MDT working effectively? Is there any sensory elements to it? Some people feel equals me because they like the sensory element of it. Diagnostic overshadowing, are they focusing too much on those sort of challenging behaviours and not looking at if there is a very real physical health element of it? Half-life of medication. With the cerebral palsy, she's quite at risk of falls, and diazepam has quite a long half-life, so that's something we probably wouldn't want to do. Menstrual cycle, you have no idea how much a menstrual cycle will affect someone, and it's such basic knowledge that people seem to completely forget that someone with a learning disability, funnily enough, has periods too if they have a womb. When was the last annual health check? So in mental health, you've got the serious mental illness check, which is the SMI annual check. And in learning disability and or autism services, you've got the annual health check. Behavioural analysis work, we want to work out if there's a pattern to it. What are the triggers in the environment? Is there something we can do? Again, is it sensory elements? Do we need to dim the lights a bit and make it a calmer environment for them and look at putting in reasonable adjustments? Lessons, yeah, we're looking at lessons learned from our past experiences. I don't know if anyone's ever done the Oliver McGowan training, heard of Winterbourne and read the leader reports. We're also going to be looking at trauma and working in a trauma-informed approach. She's a vulnerable adult at the end of the day, and we know there's been a past history of sexual assault, and people with an LD are unfortunately much more likely to be sexually assaulted and assaulted because of the vulnerabilities. And yeah, the key legislation we're going to be looking at is the Health and Social Care Act, the Medication Act, the Mental Health Act. Say if it came to needing a point of admission, a Mental Capacity Act, the NMC Code, the Equality Act, then you've got the Medications Regulations Act, which we'll be looking at as well. We look at the STOMP, which is stopping the over-medicating, I can't remember what it's for now, but it's stopping the over-medicating of people with a learning disability. And like, we don't want people to be on antipsychotics because we know they've got quite bad physical health side effects. So that's all the stuff I think of when I do an assessment, and probably much, much more that I haven't written down. That's just to say what an MDT is. Yeah, so it's just about an effective tool to facilitate collaboration between professionals and improve outcomes for people and communities. And they proactively consider how to involve individuals and families to ensure that their views and interests are kept at the centre of their decision making. So we do a lot of person-centred reviews, and we have our patients in our reviews, and we do everything we can to get our patients' voice heard. We have SALT, which is a speech and language therapist we also work quite closely with to ensure that our patients have a voice to battle those health inequalities.